So welcome to this session. As I say, I'm Andrew Curran. I'm HC's Chief Scientific Advisor and Director of Research, and we're going to be learning a little bit more today about what the PROTECT National Core Study has been doing to understand how transmission actually occurs. And from the perspective of our programme, we have a nice model that we tend to use to try and explain what it is that we're trying to do. So we believe that there are three really important key elements for us to consider when we're thinking about transmission, and they are the environment in which the individuals may be working or living or moving or out enjoying themselves, the behaviours that they exhibit in those spaces, and the characteristics of the virus itself. And it's the interaction between all of those elements that leads to transmission. And within the context of what we've been doing, there are some really important things for us to remember. But I think the most important one is that within the world of transmission of SARS-CoV-2, there are three main routes: air, surface, and person to person. And in understanding transmission, we need to understand how those three routes interact between the environment, the human behaviours, and the characteristics of the virus itself. And what you're going to hear today are some presentations that try and explore some of those issues. PROTECT was set up really to fill gaps in the research ecosystem around COVID, particularly because there were some urgent policy requirements, and those policy requirements remain actually. And what we're trying to do here is understand what goes on in the real world. So making sure that in addition to the modelled world, which is extremely helpful in looking forward and trying to think what might be happening, we're providing evidence and information to support and assess those models so that we've got the information that we need to validate them going forward. And that real world approach is very much at the heart of what we do. Clearly, one of the things that's important for us as well is to make sure that the information we provide is of value to policy colleagues around government, because the information that we provide in real time is critical to the advice and guidance that's given to workplaces, citizens, members of the public, when it comes to how to behave in different scenarios moving forward. And to that extent, we have to be rapid and responsive, and hopefully you've seen that we put some information out on Monday, just to try and get people to think a little bit about some of the key things that they need to understand to ensure that they're protecting others from themselves and themselves from others. And of course, we need to leave a legacy from the programme and make sure that the learnings that we have generated are available to future generations. You can see the themes here. I won't go into a lot of detail. We've broken it down into 6 areas: one looking at outbreaks, one looking at the transmission mechanisms, one looking at sector-specific studies, one at experimental insights, all linked by methods and tools, and ultimately trying to determine what actually works. And you'll hear across some of those themes today. We're funded as part of a much larger programme of another 6 national core studies by Treasury until March 22 at the moment, but we're hoping to get additional funding for another year after that as well. We have a very substantial team now delivering this work. We've probably got over 100 researchers now, and those researchers are drawn from 20 academic and government research institutions from around the world, but mostly from the UK. So hopefully what we'll be able to do in the session today is provide you with a bit of insight as to what we've been doing, what that means for transmission, and give you some opportunities to ask some questions of the team at the end. So this is what we're going to hear about today. First, we're going to have a presentation from Elizabeth Brickley and Adana Awuzie from the COVID Out study, looking at outbreak investigations. We're then going to move on to Nick Warren and his agent-based model for looking at risk when it comes to COVID. And then Marty Van Tongeren from the University of Manchester will be talking to us about the preliminary findings of the work that he's been doing in some of the sectors. And we hope then to have time at the end for questions and a panel discussion. So that's the plan, and without further ado, what I'm hoping to be able to do now is to introduce our first speakers. So great pleasure to welcome Elizabeth Brickley, who's an associate professor in the Department of Infectious Disease Epidemiology at the London School of Hygiene and Tropical Medicine. Elizabeth's recent work has included a lot of work around the world trying to understand a variety of different infectious diseases, and really pleased that she's able to contribute to this study. And we also have Adana with us. Adana's been working as a medical student and has participated in some of the work that we've been undertaking in this part of the programme. So really great to welcome Adana as well as an early years researcher who's also going to contribute to this presentation. So without further ado, Elizabeth, I will pass over to you. Thank you very much indeed.
Well, great. Thank you so much, Andrew. And I'm delighted to be here with you all today and to talk to you about the COVID-OUT study, so COVID-19 Outbreak Investigations to understand workplace SARS-CoV-2 transmission in the UK.
So thank you for the introduction, Andrew. Good afternoon, everyone. So today I'll be presenting the COVID-OUT study, which is a part of the PROTECT COVID-19 National Core Study on Transmission and Environment. So this national core study in particular is divided into 6 themes, which are coordinated by a host of governmental agencies and academic partners. The COVID-OUT study falls under theme 1, which is Outbreak Investigations. So COVID-OUT, Outbreak Investigations to understand transmission. The overall aim of this study is to understand coronavirus transmission routes and risk factors through investigation of outbreaks in a range of occupational settings. This is a multi-agency approach as detailed by the objectives below, whereby rapid response teams are deployed to investigate workplace outbreaks. This method is standardized and teams can be sent whenever and wherever a workplace outbreak occurs to collect data for analysis. So at present, the first 2 objectives have been more or less completed, and our primary focus is now on the 3rd objective, which is identifying risk factors for SARS-CoV-2 infection among workers. And once we have enough sites, all this data will be pooled in order for analysis to answer these research questions. So Public Health England and the Health and Safety Executive undertake daily monitoring for workplace outbreaks. And for this study in particular, we prioritise large workplaces with attack rates of at least 5%, so coronavirus infections among workers, between December 2020 and July 2021, so about now. Excluded from the study include workplaces such as hospitals, prisons, and restaurants. So sites under investigation at the moment include office settings, distribution centres, manufacturing plants, whether that be food or non-food plants, and also public admin and defence, so sites such as police stations. So in order to recruit for this study, we obviously first have to identify a workplace. And once that has been notified, the Health and Safety Executive recruits a company by providing information sheets, and they obtain consent in order for the rapid response teams to access the company site for data collection and environmental surveys. Meanwhile, we also work with the company to recruit workers from their firm and provide them information and obtain consent so they can join the study. So once the recruitment stage has been completed, we can then move to data collection, i.e. the rapid response. So in the first week, environmental assessments are undertaken, so looking at ventilation, air samples, surface samples, and also do biological assessments, so nose swabs and throat swabs as well, including and another biological assessment includes blood samples for a paired antibody test, which the second of which is completed in later weeks, and a baseline questionnaire is also given to participants. In weeks 2 and 3, more nasal swabs are provided to participants only if they haven't tested positive for COVID, and follow and in the remaining weeks 4 to 6, the second blood sample is collected for the paired antibody test, really to determine whether the participants have had COVID-19 infection before, and a follow-up questionnaire is given, so any signs and symptoms participants may have had, and this will be discussed in further detail later in the study. So the following agencies, the Health and Safety Executive and Public Health England, carry out these environmental assessments and sample testing, and obviously the all-important data cleaning and de-identification of data for us to handle. So I'll now pass you over to Lizzie for the second half of the presentation. Thank you.
Thanks very much, Adana. So when we approach these workplace outbreaks, we have 4 key questions that we're really thinking about when we start our investigations. And the first is, what are the environmental conditions associated with SARS-CoV-2 outbreaks? Then what interventions and mitigation activities prevent SARS-CoV-2 transmission? What are the risk factors for SARS-CoV-2 infection among individuals? And what are the potential transmission routes of SARS-CoV-2? To begin to answer these questions, we first start with an environmental assessment. And just to note that our environmental data collection framework is publicly available on OSF, and the links to this will be provided at the end as well. And what happens is that whenever our team goes on site, our rapid response team, which includes occupational hygienists from the Health and Safety Executive, is that they want to work with the company to start to gather some really high level information about the environment. And so first they look at the site itself. And so considering things like the size, the number of buildings, the layout of workers within the buildings, environmental conditions like temperature and humidity, and also thinking about things like worker density in different zones. These can include common areas. And so in particular, we're interested in shared surfaces. So things like hot desks, as well as high traffic zones within the workplace, such as canteens, toilets, locker rooms, and showers that may experience pinch points at different points of the day. Another area that we're really interested in is ventilation. And so in particular, we've been looking at both the carbon dioxide levels as a quantitative metric of this, and also considering the ventilation measures that are in place. And so both mechanical ones and natural. We then consider the next question of what interventions and mitigation activities prevent SARS-CoV-2 transmission. And so what we're looking at here are really, first we look at the existing control measures. And we start by thinking from a policy perspective, what are the policies in place related to sick leave and pay? And then what are the practices? So what are the policies and the expectations for the workers in relation to hand hygiene, workplace cleaning, social distancing, physical barriers, and PPE that's provided to workers? We also think of what the enhanced control measures that may be in place beyond the general expectations. And so these can include things like improvements to the ventilation systems, any enhanced cleaning measures that are in place, but also thinking about how people work. And so what's the timing that a worker may be involved on a given task, or how do they work in relation to other workers? Are they placed front to front or back to back, side to side? Where are the barriers? And we also think about bubbles. And so are there groups of workers who tend to cluster together throughout the day? We've also been really interested in what the mitigations that have been introduced in the wake of detecting an outbreak. For example, are there enhanced testing measures in place? Our second main tool that we use to investigate outbreaks is called a case control study. And for this, we're really relying on a digital questionnaire, which workers can access either through a smartphone or through a computer. And we've been working with our colleagues at Public Health England to translate this into other languages as well. And in the questionnaire, we ask questions not only about what goes on inside the workplace, but also what happens outside of the workplace in the worker's home environment. Again, this questionnaire is publicly available on OSF. So what we're looking at in the questionnaire are really trying to get at these risk factors for SARS-CoV-2 infection. And so first we ask about the worker. We want to know about their demographics and their medical history. We also want to know about what their life is like. So what is their household environment? Is there crowding at home? Do they go out and about in society? Do they do things like attending the gym and travel? How often do they go to the supermarket? And then we ask about their COVID-19 experience. And so have they been vaccinated? And have they ever had a positive test or experienced symptoms that are consistent with COVID-19? And we also ask about their job itself. So what is their role? And what would be the financial implications of something like self-isolation? On a day-to-day basis, what does their work look like? And what is that environment when they're at work? And finally, what is the personal protective equipment that's available to them when they're at their workplace? one of the really key things with a case control study is trying to identify who our cases are. So who has had COVID-19? And to do this, we use two approaches. So the first approach is a prospective ascertainment within the COVID out study. And this is where we're looking for either the virus using PCR testing or the antibody to see that immune history of exposure to SARS-CoV-2. We also conduct a retrospective assessment where we look at self-reported testing and symptoms and also work with local health protection teams to gather records that could be related to this. And then our final approach is to do, as Adana mentioned, an integrated analysis. And here we're trying to look at what the potential transmission routes are for SARS-CoV-2. And here what we're doing is we're comparing workplaces and conducting pooled analyses to generate hypotheses related to the routes of transmission and their relative importance. And here we're drawing on all sources of data that are available to us. So both the COVID out standardized environmental and epidemiological data, but also local health protection teams' investigation reports and company testing data as available. So now we're at a really interesting week in the UK. And so as our office places kind of shift from looking at something like this to something more like this, it's worth spending some time thinking about what are the lessons we've learned so far in COVID out. And the first big lesson for us is that outbreaks happen when production demands are high and workers cannot work from home. Protective measures should be applied proactively, and returning workers need to be carefully monitored and managed. We know that workers experience risks not only at work, but also on the journeys to and from work and in their home environments. And measures to identify new infections introduced to workplaces, so things like testing, and to rapidly control transmission, so things like tracing, isolating, and sick leave policies within workplaces are important for preventing and limiting the size of outbreaks. Our second big lesson is that risks are never equal within a workplace. So even in workplaces with robust COVID-19 control measures in place can experience outbreaks. And COVID-19 control measures are not applied systematically within workplaces. And we also know that their adherence may vary by person, place, and time. In particular, one of our key observations from our site investigations has been that social distancing is a particular challenge in many workplaces. We also know that attack rates, so that is the proportion of at-risk workers who become infected, can vary significantly between and within workplaces. So in one really striking example, we could see that 0% of workers in a warehouse were infected, whereas their colleagues who worked on a specific assembly line, it was up to 1 in 3 workers were infected in a given outbreak. We also know that another big lesson for us is that groups with high risk can be difficult to engage in research. And 2 groups of special concern for us are agency or temporary workers and migrant workers. And with the agency workers, we know that they're often at higher risk of exposure through, in particular, their specific job roles. So for example, they may be more likely to be involved in cleaning staff, but they can also be difficult to reach. For example, they may lack company email and they may face different pressures related to isolation. For example, they may be on precarious contracts or face losses in pay for isolation. We're also really concerned about migrant workers. So most obviously for the language barriers, and we've been working with our colleagues to try to get around that and think about how we can better engage with migrant workers. We also know that more generally, migrant workers face increased infection risks because they're more likely in some cases to experience more difficult situations outside of the workplace. So for example, they may live in more crowded housing conditions or be more likely to live in dormitories. They may also have differential access and uptake of healthcare and vaccines and face pressures related to their immigration status. So a final key lesson for us is that ventilation should be a priority. We know that ventilation can reduce airborne transmission of the virus. And what we've seen in the COVID outbreaks is that insufficient natural mechanical ventilation is a common finding in the places where we see high attack rates. This is a real challenge though, because ventilation is invisible. It's easily forgotten, poorly monitored, and changes to ventilation can be expensive for companies. And so monitoring CO2 is one tool that can help us to identify spaces with poor ventilation and high risk of transmission. We know that carbon dioxide levels are a proxy for exhaled air, and monitors can be a really cost-effective tool to identify areas with inadequate ventilation. But it's important to bear in mind that monitoring CO2 does not directly mitigate COVID-19 risks. So once an area is identified, it's really important that companies then follow up with further interventions to improve that ventilation. And finally, so as we kind of look forward with these studies, one thing that's really important to us is public engagement. And we view this as a two-way process of interacting and listening. And our goal is to adapt the research to reflect perspective and concerns of the public related to staying safe in workplaces, the lifting of restrictions in step 4, and what it's like to participate in research like COVID Out. And so please do be in touch if you're interested in learning more or getting involved with this research. And so to wrap up, as a real-world observational study, COVID Out brings strengths and limitations. It provides critical evidence in the near term to inform the national COVID-19 response and offers a unique breadth and depth of standardized data collection. But we also face challenges, in particular in responding rapidly and achieving a high participation rate in the studies. We also face an evolving epidemiological landscape due to changes in vaccination and also the emergence of new variants of concern. And we're continually adapting to new outbreak settings and new policies. And so with that, I'd like to thank you all for attending, and also to thank in particular my colleagues. And so in particular, Yi-Chen Chen, who's our technical lead from the Health and Safety Executive, as well as my colleagues from Public Health England, London School of Hygiene and Tropical Medicine, and the University of Manchester. Thank you very much.
Thanks very much indeed, Lizzie and Adana. Really clear presentation and illustrates very nicely, as you said, the practical nature of what PROTECT is all about. And we shouldn't underestimate how difficult these studies are to do, and to get into real workplaces during outbreaks and collect data at the scale that you described is a fantastic achievement. We have time for a couple of questions, and there's a couple in the chat. So the first is from Damien McElvenny, and question for you, Lizzie and Adana, about the assumptions that you might make about the timing of infection or transmission in asymptomatics in the analysis of the pooled case control studies, and how time-related effects are dealt with in general.
Yes, so this is something that is really challenging. And so when we approach this, our first approach is basically we use this two-tiered approach to looking at analyzing who our cases are and who they are not. And we want to know who has been infected in the past. And so to begin to get at that, we use the combination of the antibody tests, which tell something about the immune experience of the individuals. So we know who may at baseline have had a previous infection or who has been vaccinated in the past. And we also use the viral testing to look at the acute infections that come up in an outbreak. And we also have to kind of layer onto that information around symptoms. And so one challenge that we really can't get around is the challenge of working out the timing for those asymptomatic infections. And so what we have to do is work with our assumptions related to the antibodies. And so we look in particular for seroconversion to see if individuals go from having no antibodies to having positive antibodies during the study period as a way to kind of place them in our timeline. But that is a real challenge and something that we think a lot about.
Brilliant, thank you very much. Next question is from Chris Harris. It's about ventilation, and Chris wants to know if you separated extract ventilation from the down from above kind of ventilation, the plenum.
So I'm going to have to, I'd like to follow up with you separately afterwards for that, because that's an area where I have to nod to my health and safety executive colleagues for an answer on that one. What I will say is that we are, in looking at our environmental data collection framework, looking at the different types of ventilation that are available, considering both the kind of the flows that you get. So things like thinking about if there are fans placed in front of natural windows, but also thinking about the HVAC systems and thinking if we're using recirculated air or if that's fresh air that's being pumped in. But I would be happy to connect you to folks who can answer that question directly.
Brilliant, thanks, Lizzie. Next question is for Adana. And Adana, how confident are you in the answers provided in the questionnaires? And more specifically, do you think there might be biases, such as people giving you the answer that you want to hear? And Daniel notes that self-reporting behaviour studies are not as reliable as observational studies. So how confident are you in the answers that you got in the questionnaires? Thank you.
So, hello, Daniel. So good question. I think for any questionnaire given, there will be biases, but in terms of how confident I am for this questionnaire, I would say pretty confident in the sense that the participants taking part and filling out the questionnaire have elected to fill it out. They've taken time out of their working day and are clearly quite interested and want to maybe help out the study and the questions in the questionnaire, which is public available, as we've already said, aren't leading questions. So they encourage participants to be as open and honest as possible in their own way. And no, I would say I'm fairly confident, and I think with any study that anyone conducts, there is always the potential for bias, but everyone in their studies have ways of mitigating against this. So that's my answer to you, Daniel. Thank you.
Thanks, Adana. Lizzie, I don't know if you want to add anything to that as well.
No, I think one thing to bear in mind is we really are thoughtful in our approach to working with workers, and we want to make sure that we don't jeopardize in any way their relationship with their employers and to put them in a position. And so we take really kind of extraordinary steps to preserve the confidentiality and to de-identify at every process, and so that the workers' information is separate from what's provided to the employer. Although we do feedback findings in order to implement public health responses, we want to make sure that we aren't biasing the study by kind of any perceived risks about lapses in confidentiality.
And time for a couple of very quick questions. So the question from Hilda about talking to union safety reps in the workplaces. Is that something that we do? Yeah.
So that is something that we are very, very keen to do, and we are just starting on that process. So that was one of our lessons learned, actually. In the first few outbreaks, that wasn't something that we had done, and now it's something that we're shifting, really putting a lot of energy towards moving to doing that. And we think it's vital to speak to the trade union reps.
Thanks, Lizzie. Totally agree. And from Gavin, is there a guidance on what is considered good ventilation in regards to litres per second per person in a large-scale manufacturing environment where people are working on a production line at a fixed pace? If I can come in there, there is guidance, and it's just been updated this week, I think, on the HC website, and also CIBSE have some excellent guidance in this space as well. So probably that's the best place to start. And if there are sort of any gaps in that guidance, very happy to for you to contact us, and we can see what we can do to provide any additional information. Excellent. Thank you very much indeed to both Lizzie and Adana. Really clear presentations and set us up well for the session. So let's move on now to Nick Warren. So Nick is a principal statistician and epidemiologist at the Health and Safety Executive. Nick's got loads of experience at looking at human health and exposure data to understand risk more effectively, published extensively in the theory in this area, and has been working on developing with colleagues an agent-based model, which Nick will now tell us about. So Nick, over to you.
Good afternoon, everyone. Thanks very much, Andrew. Let me just move over, hopefully. Right, can people see that, Andrew?
Perfect.
Yes?
Yeah. Go for it, Nick.
Perfect. All right. Good afternoon, everyone. So I'm going to talk about the agent-based modelling of workplace transmission. And so the aim of this work is to develop and apply a mathematical model for virus transmission in workplaces, to understand how outbreaks occur and propagate, how effective various control strategies are at mitigating those outbreaks, and also in particular to sort of link this transmission modelling to other kind of higher fidelity models of virus emission, dispersion within environments, and in-host models. And so what we've got shown on the right-hand side of the screen is the sort of ecosystem of modelling that's going on in theme 2 of the Protect programme, with a number of different partners. And so this is work package 2.1.2, the transmission models. But like I say, it's part of an ecosystem, and we're very much trying to not develop these models in isolation, but to have results and outputs from one model flowing into other ones. So, for instance, the droplet models that characterize the emission, they can feed into ventilation models. The ventilation models can feed into the QMRA models, which are risk assessment models for transmission over short periods of time. And then findings from those can feed into the model I'm talking about today, which is looking at transmission over multiple generations of transmission at an enterprise level, at a workforce level. And just to sort of clarify the scope, it's intended to be a generic workplace model, or a model that can be tailored to lots of different types of workplaces. But we are focusing on workplaces that don't have significant numbers of transient individuals. So most of the people in the workplace are there because they work there, as opposed to them being members of the public who are traveling, shopping, eating, drinking, etc. So this model excludes retail, hospitality, hospitals, care homes, for that reason. And also some of those other areas have been very well studied and modeled with specific models. And so we're sort of trying to focus more on actually the very much larger number of workplaces that have had less specific modeling undertaken for them. So the model itself, it's a pretty kind of standard SIR epidemic model. It's individual, so the agents are the individual workers. It's stochastic, and we simulate the interactions between workers over time, and those interactions determine the transmission between individuals. We don't consider, it's only a model for transmission. We don't consider symptoms or hospitalizations or deaths. And it's kind of got most of the kind of standard features in terms of incubation periods and symptomatic and non-symptomatic individuals, etc. It runs on a contact network. Where it differs slightly more, perhaps, from some of the other models, epidemic models that are around, is in how the transmission probabilities are calculating. So it uses an exponential dose response, and it depends upon not just who you have contact with, but what distance those contacts occur at, how long the contacts last for, and then that's modified by the workplace environment, especially ventilation, face coverings, the infectiousness of the individual on the specific day. And the infectiousness of the individual is linked to their viral load. We model viral load using a simple exponential proliferation and clearance model. So that means that individuals' infectiousness is changing over time through the time course of their infection, but it also differs between different individuals. And we know that some individuals are more infectious and they have higher viral loads. One of the extensions that we hope to do in the near future, and this links to one of the other work packages in theme 2 of Protect, is to have a more comprehensive sort of in-host viral dynamics model. That, because at the moment we're linking viral load to infectiousness, but there's a step in between that, which is sort of exhaled virus or shed virus. We're gathering data in Protect on that through in-mass sampling, and also I think through the human challenge studies. And so we want to use that information to improve that aspect of the model. The contact network. So the contact networks, see an example of one on the right. The nodes are the individual workers. The edges are that depict that those workers have contact between them. We actually use 2 contact networks. So we use one contact network for short, close contacts under 2 meters, where transmission is predominantly via large droplets. And then we have a second network, which is for medium proximity contacts, ostensibly kind of 2 to 5 meters, where the primary route of transmission is going to be finer aerosols. And then we weight the edges in the contact networks by the cumulative daily duration of contact between that pair at that distance. We've got multiple networks for different days, and so we shuffle the networks to simulate changing contact patterns from day to day. And obviously in some workplaces, contact patterns might vary a lot day to day, and in other workplaces, people are doing very much the same thing in the same place, in the same proximity to the same workers each day that they're in work, and there'll be less day-to-day variation. In terms of data sources for this, so we've got a number of different data sources. I think it's fair to say none of them are as good as we would like. We're making heavy use of some high-resolution pre-pandemic office contact data that was collected using wearable tags, and that gives us close contact, medium proximity contact, the duration of those, and then we have some other data, some other data sources. There's quite a lot of data from contact surveys, but I think one of the key things there is they only give a partial picture, because they only typically ask, or maybe always ask, about close contacts rather than contacts over sort of greater distances or proximity events over greater distances. And usually also they don't include the duration, information on the duration the contacts lasted for. And obviously in a workplace, there's a lot of variability in workplaces, perhaps more so than in a household. So you encounter the same people in your household each day, and you're going to have a lot of contact time with them, both close contact and contact at 3 to 5 meters, etc. Whereas in the workplace, it's just workplaces are incredibly variable places. So there's a lot more variability there. And then the fourth data source, which I've highlighted, is a new study that has been just about to come online within Protect, that's going to collect this high resolution data using ultra wideband wearables. So that'll collect distance, duration, and the location that the contacts occur within the workplaces, coupled with a survey that gathers information on workers' attitudes and workplace controls to try and understand how they influence contact behaviour. And this will be done in multiple workplaces, but the data aren't yet available to us. So in terms of model outputs, one of the good things about these models is there's a huge array of model outputs that can be extracted from it. So those are both at the workforce level and at the individual level. And I'm just sort of showing some examples here. And I think probably the most important thing to take from it is the highly stochastic nature of the outcome. So all of these simulations here are for the exact same scenario, if you like, the same conditions, the same transmission parameters, the same contact patterns, etc. And what we're just seeing is the kind of stochastic variation following the introduction of a single seed case into the workplace. And so we see in the middle one, in terms of the outbreak size, that you can get lucky and introduce an individual who's infectious, and they won't infect any of their colleagues or very few of their colleagues, and nothing much happens. But equally, certainly under the conditions depicted here, you could introduce a case and have, if it was not mitigated, if mitigating actions weren't taken, you could have a outbreak that goes through the majority of the workforce. And so you can be lucky for quite a while, but there aren't just single introductions of infection into workplaces. Over time, it's going to be introduced multiple times, and so eventually, your number is going to come up, as it were, at a workforce or workplace level, and that outbreak's going to occur. So just in terms of transmission rates for workplaces, in absolute terms, absolute levels of workplace transmission remain pretty uncertain, and that's because, fundamentally, we don't have a list of where everybody contracted the virus. So we don't know what proportion of the total societal cases are from the workplace, or not easily anyway. And in any case, it's likely to vary very substantially between different workplaces, both between different sectors, but also different workplaces within the same sector. So our approach has been very much to sort of try and determine a plausible parameter space for rates of transmission at the two distances per unit time, if you like, and determine that credible space using various available information sources, in particular secondary attack rates, both from specific workplace outbreaks, but also the secondary attack rates of workplace contacts that are reported through UK test and trace. So we've using that, we've defined a plausible region for the transmission rates per unit time. If we then feed those through the model, what we get on the right-hand side is a sort of depiction of what the overall workplace level of transmission is in terms of a workplace reproduction number, if you like, which is the y-axis, and then the proportion of the transmission that's due to the medium proximity contact. And I think the critical thing to take from this figure is, with these contact patterns, and I must emphasize that, it would be very difficult you'd be unlikely to get an outbreak. And if you did get an outbreak, it would be small scale, unless the majority of transmission is occurring via fine aerosols, via contacts that are greater than 2 meters in terms of separation, or alternatively, there was widespread fomite transmission as well, which isn't explicitly considered by this model. And so I'm going to present some results relating to control and mitigation strategies. And essentially, we've explored the blue parameter region, and I'm going to show some results that relate to 2 particular points in that parameter space. So one is a kind of high level of overall transmission that's predominantly occurring via fine aerosols and is to do with the sort of medium proximity contacts. And then the second set of results that I've picked out relate to a lower level of transmission that's primarily via the short proximity contacts and larger droplets. So these are the different control and mitigation strategies that we've evaluated. I've not arranged these according to the sort of standard occupational hierarchy of control, but more to do with sort of mechanistically how they are acting to prevent workplace transmission. So there's a bunch of mitigation strategies, control strategies that are to do with kind of keeping it out of the workplace in the first place. Then there's the ones to do with sort of workplace social distancing, which is cutting down on the frequency of opportunities for transmission to occur. And then the third category, which I put vaccination in as well, relates to reducing the transmission risk between individuals when contact does occur between them. There's a lot of assumptions and caveats that underpin all these control things. I'm not going to comment on this, other than to say some of the evidence base for some of these controls is more developed than it is for others. So I think there's particular uncertainty around workplace social distancing and how that influences contact patterns. And I think the other thing is that these are all sort of idealized control scenarios. I mean, there's almost an infinite number of variations on each of them in terms of the frequency with which you perhaps test people, which days of the week you test them, where you test them, etc. And so in reality, you know, the control approaches need to be tailored to the specific circumstances of the workplace. So in terms of results, I think so here we've got the 2 different levels of transmission and different flavors of transmission, if you like, that I described earlier, and then the reduction in the workplace reproduction number and the overall outbreak size that would occur following the introduction of a single seed case. And I think there's a number of kind of things with this. So first of all the measures make a meaningful reduction in transmission. Secondly, none of the measures individually, with the possible exception of very substantially reducing the building occupancy, are likely to be adequate to control transmission singly on their own. So you're going to need a package of measures in reality. Thirdly, the effect of vaccination or partial vaccination of your workforce is a similar order of magnitude as these other controls. Fourth, the effectiveness of some controls depends upon the route of transmission. So increasing the room ventilation is very effective when most of the transmission is occurring via fine aerosols over greater distances, but if most of the transmission is via larger droplets, then it's going to be a lot less effective. And then the final kind of observation would be that the reductions in outbreak sizes are generally considerably greater than the reduction in the workplace reproduction number. So we've looked at these in isolation, and we've also considered the effects of controls in combination. And so I'm just going to finish with, how vaccination sort of possibly changes the control requirements in the workplace. So taking that high transmission scenario again, sort of unmitigated baseline reproduction number would be about 2.5. If we add in twice weekly lateral flow testing, we take a substantial fraction of that away. We increase the ventilation, and now we've got the workplace reproduction number under 1. So the likelihood and scale of outbreaks is going to be small. But we're still at a level of transmission which, if this was the level of the average level of transmission across all workplaces, then it would be impossible to control transmission at a societal level if that was the aim. So if we add on reduced building occupancy, now we've kind of got the workplace transmission down to a level that possibly is compatible with control of transmission at a societal level. So that was all with an unvaccinated population workforce. With a vaccinated workforce, using data on age-related uptakes to July 4th, with no other mitigations, then we're still above a reproduction number in this workplace of 1. So outbreaks are still going to be very likely. If we add in our weekly twice weekly testing, we're probably sufficient to prevent outbreaks, but we've still got a high level of transmission overall, or a high contribution to societal transmission. Our increased ventilation probably gets us down to the sort of level that we might need to achieve. And of course, this is all very much dependent. So it's a bit like a menu, really. And so without vaccination, you might need 3 or 4 courses from the menu. And with vaccination, you can perhaps only have 1 or 2. But it's very much dependent on what the baseline level of transmission would be without any vaccination and without any workplace controls. And of course, that varies with workplace-specific conditions. So knowing what that is at the outset is tricky. So just to finalize my kind of summary of some of the main things. So the outcomes are very stochastic at an enterprise level. Large-scale outbreaks are highly unlikely through close contacts alone. We need transmission over greater distances. And then the effectiveness and the practicality of controls is context-specific and influenced by the predominant routes of transmission in the workplace under consideration. And vaccination can reduce the necessity of workplace controls, but with current levels of vaccination, many workplaces would still require additional controls if outbreaks were to be prevented. So I think I've probably spoken slightly longer than I should, so I will stop there. Just acknowledge some of my HC colleagues and other people within Theme 2 of Protect.
Thanks, Nick.
Thank you very much, and back to Andrew.
Thank you. And we have got a couple of questions. I'll take just a couple of quick questions, then we'll come back to them at the end. So there's the first question from Jackie Waldridge about whether you've got any idea about the percentage of contacts who go on to develop COVID infection, and whether that varies by type of contact, e.g. household, workplace, car share, etc. Very quick answer.
So we do have some idea. So I mean, it obviously is being changed with the Delta variant. So I think prior to the Delta variant, household secondary attack rates were about 30%, maybe a little bit higher, depending on occupancy levels and so forth. The overall secondary attack rate of contacts reported to test and trace, workplace contacts reported to test and trace, is about 5%. So that kind of gives some indication of it. Yeah.
Thanks, Nick. One final question before we move to the next presentation from Damien McElveny again. Are you able to bring any further evidence to whether avoiding contact within 2 meters for more than 15 minutes remains appropriate? If not, can track and trace data provide evidence on that?
So I think my view is that, I mean, the 2 meters is not some magic level. You know, the risk doesn't go to zero beyond 2 meters. And I think what we're, increasingly concluding from a variety of evidence sources is that maybe the majority of transmission in the workplace is occurring through being further away than 2 meters. So avoiding close contact in many situations may not be as effective as people generally suppose.
Thanks, Nick. And we'll pick up on the other questions when we come to the panel session at the end. So please hold on to them. I'll come back to them over time. Thank you very much indeed, Nick. Really great presentation, and demonstrates, I think, the opportunities we have to test some policy options before actually implementing using the evidence base you described. Okay, let's move on to Marty. Marty, many of you will know, I'm sure, Professor of Occupational Environmental Health at the University of Manchester. I won't give the number of years, but lots of experience in occupational and environmental exposure assessment and epidemiology, and great pleasure to have him leading one of the themes in Protect. So Marty, over to you. Thank you very much.
Thank you, Andrew. I'm unable to share my screen at the moment, unfortunately. So it says host disabled participant screen sharing. So
okay, so hopefully our colleagues from Manchester can help us with that. And we'll get the screen available to everybody. There we go. Thank you.
Can you see that now? Okay. Well, thanks, Andrew. Thanks for the introduction, and thanks for organising this this session, and also kind of organising the whole Protect study, which is a fascinating kind of collaboration and piece of work. So I'm delighted and very honoured to be involved in that. So I'm presenting some findings that are part of theme 3 of Protect, which is about kind of work-related risk and sector-specific investigations. So theme 3 within Protect is as I said, it's mainly looking at sector-specific studies. We're doing qualitative and quantitative investigations in sectors such as public transport, construction, and food processing. But we're also kind of looking at how we can use existing data to carry out complementary kind of statistical analysis to improve our understanding of the role of occupation in the risk of infection. And all this information, as well as information that's collected from the work that is carried out in theme 1 and theme 2 and other themes, will hopefully use that to develop what we call sector-specific evidence reports that we will publish later on the kind of websites. So first of all, I want to kind of share with you some results of analysis that we did in collaboration with ONS and the London School of Hygiene looking at kind of mortality due to COVID-19, mortality due to COVID-19 and the role of occupation. And ONS have published last year kind of analysis by looking at kind of mortality by occupation, but their kind of analysis were not able to kind of take into account kind of confounding factors such as geographical, social demographic characteristics, etc. Now we kind of made use of a linked data set that was based upon the 2011 census data in England that was linked to primary care records and also mortality records, and that allowed us to take into account confounders and mediators such as these geographical factors, social demographic characterizations, and pre-pandemic health. Obviously, the downside of that is that we had to rely on 2011 information on occupation, which is somewhat of a problem, and hopefully can be resolved kind of going forward when eventually 2021 census data become available. But we felt confident that at least for some occupations, and particularly in the age group that we looked at, there was some stability, and it wouldn't unduly bias kind of our result. So what we find was very interesting. And somewhat surprising, I guess. So if we just kind of looked at age adjustment, and these are the kind of bars in pink in this graph on the left, you see kind of similar kind of hazard ratios as were observed originally by the ONS. So for example, taxi and cab drivers, you see hazard ratios is about 5, kind of other elementary occupations just over 4, care home workers just about 4. So very similar to and high hazard ratios, and indicating that occupation, or suggesting that occupation is an important factor in transmission and risk and mortality due to COVID-19. However, if we then kind of gradually include different factors in the modeling, so if we take account of geographical differences, if we take account of deprivation, if we take account of household structure, ethnicity, and pre-pandemic health, then we see that these kind of hazard ratios and these are compared to corporate managers and directors, kind of reduce quite dramatically for a number of these. So for example, the taxi drivers, again, they kind of reduce from about 5 to about 1.5. So not disappearing. So occupation and occupational exposures are remaining an important factor, but it suggests that occupation is a marker of many other things than just occupational exposures, and that other factors are kind of like contributing to these kind of effects. And hence it's important that when doing these analysis and when trying to kind of infer conclusions about the exposures that happen in the workplace, that some of these other factors are taken into account. This is another slide which is from the same study that is published in one of the preprint sites, and we've submitted it to the OEM journal at the moment. And that again shows a similar kind of picture. We can see that essential workers are kind of at increased risk, and this time it's compared to non-essential workers, and it's about 1.45 hazard ratio. If you kind of fully adjust it, it's somewhat reduced, and that you see that similar picture in men and women. The effect is somewhat less if you look at the kind of health associate professionals. So what I mean somewhat less is that the reduction after you've fully adjusting for these other factors, it doesn't kind of result in a reduction in the hazard ratio. So it's not necessarily across the whole board that these reductions occur. So that's a kind of an important early observation, and I think I want to repeat that I don't want to kind of suggest that occupation isn't an important factor. I think it remains a very important factor, but it's very, very interlinked with other factors too. Next, I want to kind of share with you some information and results we had from some sector-specific kind of investigations. And some of these results, some of the results that I'm presenting was also kind of presented yesterday in a session on transport. But we done within the transport sector a kind of a deep dive that involved looking at evidence from other studies, looking at the literature in terms of transmission risk in ground-based public transport. And we've done a qualitative study interviewing many different stakeholders within the public transport sector. This first slide shows why, again, why transport workers is important and interesting, and these are now based upon initially based upon the ONS results that were published last year, based upon mortality between March and December of 2020, and it shows that these taxi drivers and bus drivers are at a rate of have a much higher rate of COVID-19 deaths than all men aged 20 to 64, and also compared to large goods and vehicle drivers and van drivers. So it is an important sector to take into account. Again, this is now the results that I presented earlier, the same table, but highlighted some different occupations, and it shows these kind of these effects of taking into account these other confounder of effect modifiers, and it suggests that the reduction, it shows again the reduction in hazard ratios for taxi drivers, bus drivers, van drivers, and other transport workers. And one of the kind of observations from this is that now after fully adjustment, the differences between the different transport workers is much reduced. If we then kind of also look at other kind of evidence from other studies from the UK, PHE done a case control study looking at occupation. We have data from Virus Watch. We have a Norwegian study which looked at different transport workers in wave 1 and wave 2. We have Biobank, etc., etc. So if you eyeball this kind of forest plot, you can clearly see that on the whole there's many more kind of like dots that are on the right of this red line, so that the rates are increased in this in these occupations. Often the confidence intervals are wide and include the kind of one, but also occasions that are clearly significant effects of these occupations compared to the comparisons groups. However, it's clear that the results vary both between studies and within studies, and also over time. So we next done a kind of a literature review that looked more at the kind of environmental and transmission risk within the public transport, and this really was more about the people who use public transport, and we tried to kind of like see what the evidence was of the presence of SARS-CoV-2 in air. What do empirical studies show us about transmission in public transport? What evidence is there of the effectiveness of control measures, and what does risk modeling for COVID-19 and transmission rates on ground public transport show us and tell us? And these kind of we found we included about 28 papers in this study, and that were a mixture of modeling and empirical studies, preprints and peer-reviewed, etc. Only 2 of these studies were conducted in the UK, although I have to say that there are currently a couple of studies ongoing which will be published later on, and will provide good, strong evidence for the UK too. But when we kind of like finished our literature review, it was clear that the sparse kind of data in published work so it's not a huge amount of information. Empirical studies provide evidence that transmission can occur, and there was some evidence of studies in China that suggested that that outbreaks can occur if passengers share kind of minivans and buses, but also on trains, and that factors such as proximity and duration of travel kind of are important. There are also kind of studies that try to kind of measure surface and air contamination in public transport settings, and these provided kind of mixed results. And to be honest, that's not that necessarily too surprising, because this is a really complex and difficult area, and hence why we have a whole theme kind of dedicated to that part of the work. And further on, the kind of modeling approaches really kind of could do, as you know, as the modeling approaches that Nick kind of showed earlier, really kind of need kind of real world data to best inform their utility. So we then continued with interviewing a fairly substantial number of people within the public transport sector, and that included kind of people that we considered experts, both kind of research, kind of government, industry, and unions, and we also kind of interviewed workers in the rail and bus sector as well as passengers, and the passengers were a mixture of both current and lapsed users of public transport modes. And the overall kind of main messages out of these interviews were that the perception of risk on public transport actually was low, and that was actually across all the response groups. However, it has to be said that this was, you know, very much affected by the timing of these interviews, which happened earlier this year when public transport numbers were actually quite low. Mitigations were generally seen as kind of effective at reducing transmissions when they're all together, but it kind of relied on trust and behavior of compliance by both workers and passengers. And enforcing some of this is very difficult, and I think particularly kind of some of the employees felt that it was often difficult for them, and they felt not in the right place to try to enforce these measures when they kind of observed passengers not adhering to some of these behaviors. And we're lacking kind of objective data, so that was still an issue that was brought up by many of the people that we interviewed. So we're lacking objective data about effectiveness of different mitigations in isolation and together, and particularly when passengers number kind of rise and social distancing will reduce, it was really kind of unknown by the people that we interviewed what the consequences of this may be. Okay, so that was some of the work that we've done in the transport sector, and the work that's still continuing. We've also kind of have another focus on the food processing sector, and we basically want to kind of look at what are the workplace factors and workforce characteristics that are associated with risk of COVID-19 among the workers. And again, we're making use of various sources of information, literature review. We have our own kind of, we're developing and implementing a survey in the sector, which includes both quantitative and qualitative tools, and we'll hopefully make use of some of the information that's made available through the COVID Out study that involves some of the food processing sector, as well as the analysis that some of the analysis that are presented before, and this will then feed into the kind of sector specific reports that we presenting. So we're there at the moment. We've done we carried out a baseline survey in 3 subsectors of the food processing sector, and asked some basic information that includes the number of workers tested positive, as you can see here on the right, and that varies somewhat between the different periods. But really, kind of, we want to kind of soon starting with follow-up surveys that include, and in that telephone survey with the companies, stakeholder interviews across the sector, and also kind of questionnaires of workers, and then again a further interview later on of a subsample of these people, so of our participants. So quite a lot of work planned in here over the next coming months. And one of the interesting thing about the food sector actually is this apparent kind of contradiction when you look at some of the results that are currently available. So on the left, again, a kind of forest plots, and you may not see the text, and I apologize for that. But really kind of like it shows a similar kind of plot that I shown earlier, based upon data from studies that have been published. So it includes a PHE case control study, it includes biobank, it includes the Californian excess mortality study, and the kind of ONS mortality study that we've carried out and reported on. And the main kind of message here is that apart, I think, from the excess mortality study in California, where they did demonstrate that pandemic mortality in food processing workers is higher than pre-pandemic mortality, and that was raised by about 40%. Other kind of studies didn't really show much support for an increased risk of mortality or infection or disease in food processing. Now, on the other hand, we have some results that were published by Yichin Chen from the Health and Safety Executive, based upon UK outbreaks data. And the table on the right shows that the top sector really is the manufacturers and packers of food, where the outbreak rate, and that is the number of outbreaks in the facility per 100,000 facility, is much larger in the food processing compared to other kind of facilities. And that's an interesting kind of observation, and something that we haven't really kind of understood yet why that is. It might be that there is some differences in terms of coding. I mean, the table on the right is based upon industry coding, while the table on the left is more about occupation, and that might cause some of the differences. So there are a number of reports in food processing in COVID outbreaks, mainly in the US. So hence, it's an important kind of area. As I mentioned, food had the highest outbreak rate. Published studies of mortality and infection, on the other hand, generally do not show an increased risk, and we still need to kind of really kind of investigate that further. And we're planning a number of further investigation that hopefully shed some lights on this. So finally, then some observations from my part, and I think this is also something that's come out of other elements of PROTECT, is that transmission is a continuous risk. And I would say that work-related exposure is important, but exposure is not contained to the workplace, and non-workplace factors can explain some or large parts of the differences in risk between occupations, but probably also vice versa, I should say. Results vary quite importantly between and within studies, depending upon design, timing, and inclusion of confounders. And we want to kind of do some further work on kind of analysis of various data sets, such as ONS, the longitudinal linkage collaboration, and we've also now kind of working quite closely with VirusWatch to help us understand better the reasons for these differences, but also using triangulations to come up with a coherent understanding of what the work-related risks are. Finally, I think sector-specific studies can help and support sectors to mitigate risk of transmissions and outbreaks. And hopefully this will all be demonstrated in our sector-specific reports that will be published later on. That's a list of acknowledgements: University of Manchester, HSE, London School of Hygiene, ONS, and IOM. And thank you very much for your attention.
Brilliant. Thanks very much indeed, Marty. Really important work. Again, delving into some of the issues at that sector level, which I think are really important for us to understand when we're looking at mitigation and dealing with the situation as it's presented to us at the moment. A couple of specific questions before we go into a more broad panel discussion. So Marty, let's just move up So, question from JP. Are there enough details in the data to distinguish the type of taxi vehicles used, e.g. black cabs, where passengers sit at the back, separated by physical barriers with driver versus normal private vehicles? I think this is a really interesting point, actually, and illustrates the fact that you need to understand exactly what people do. Certainly on bus drivers, a lot of bus drivers are separated from their passengers. They're not actually in contact with them for very long. They drive in a cab that's often closed off, and contactless payment means that there's no interaction. Have the windows open, and we have found in some of the outbreaks that it's the meetings that they all have together in the morning where the most likely transmission is occurring. So understanding that complete mix of what people do is important. But Marty, what's your view?
Yeah, definitely important. Unfortunately, the some of the existing data sources that we use don't have that level of detail, and often we're very pleased if we have an occupation included in some of these analysis. But we don't often know exactly what they were doing during their work. We are developing a kind of a job exposure matrix, or I have developed a job exposure matrix that helps us translate some of these occupational codes or occupations into risk factors. But again, generally, when you're looking at ONS data, mortality data, that level of detail is not available. And hence, I think it's important to have these combination of studies.
Thanks, and totally agree, Marty. Question from Chris Harris about food manufacturing, suggesting that they take place in slightly over atmospheric pressure environments, which prevents the ingress of dust and bacteria. And Chris suggests that must lead to turbulence around workers and other effects. Also, high risk to low risk air movement is common, and the majority of workers work in this lower risk area. Do you think it's worth detailed investigation?
Well, I think particularly in the work that Lizzie presented earlier, I think environmental factors within outbreak investigations will be important. I think and food has a particular often a particular climatic conditions. Sometimes it needs to be done under cool conditions. So I think it's very difficult to kind of say, well, one particular element will be the main factor. I think there will be a combination of factors that is important in the food processing. That could be temperature, humidity. It could be the fact that the type of demographics of workers that are involved in that study, in that sector, how they where they live, how they go to work, what they do outside work, also what they do during their break, what break facilities are available, etc., is also important.
Yeah, thanks, Martin. Totally agree. And I know that the environmental measurements that we're making in a lot of these places show that we can detect viral RNA in a lot of those places that you talk about, particularly the workrooms, the canteens, the on top of lockers, washrooms, etc. So clearly it's not just the work activity that the factory is designed for, it's the work associated activities that perhaps people don't necessarily think enough about. Excellent. We might pick up some specific questions as we move into the sort of more panel discussion, but if I could ask all of the panel members just to switch themselves back on in relation to cameras, and we'll have a more general kind of discussion, because I think there's been some really interesting questions raised throughout the morning, and clearly there's been a bit of a focus on work. So my first question to the panel really is, do you think it's work itself or the workplace acting as a setting where risk factors coalesce that is the thing that we need to think about? So is it the work activity, or is it the fact that work just acts as a place where different risk factors come together that is responsible for transmission in those environments? Let's start with Lizzie.
Sure, thanks Andrew. That's a good question. I think you're right that it's a place where risk factors come together, in that particularly, especially when we were in the lockdown periods, it was one of the places where we had people physically meeting and bringing with them the exposures that came from the rest of their lives together. And so when we think about workplaces, it's really important that we kind of approach it from a layered risk management perspective. we think, how do we protect individuals? And so our strongest tool for that is thinking about vaccinations. And then we also think about how do we stop transmission if someone does introduce the virus to a workplace. And so there we're thinking about things like ventilation, distancing, face covers that particularly block the respiratory route of transmission, but also thinking as well, to a lesser degree, but still important, around hand hygiene and how do we block the surface transmission that might be happening as well.
Thanks, Lizzie. I'll move to Nick for any comments on that.
I don't think I've got a lot to add to that, really. I mean, I think it's very much just an environment where transmission can occur. I mean, it's obviously got its own characteristics, which are varied and slightly different to other environments, but fundamentally the transmission's occurring because people are near one another in a workplace, as they are in a house and as they are in other public places. So I think it's an environment where the same issues are taking place in a slightly different way with relation to transmission.
You're muted, Andrew.
Apologies, first one of the day. I just made a comment in the chat that if people would like to make a comment in person, very happy for you to raise hands, and we can open it up in that way as well. So Damien, you were first off the mark, so over to you.
Yeah, just picking up on this specific question you asked, Andrew, there must be some occupational activities that do spread the risk of the virus. So I don't think it's totally an accident of being in a workplace. You know, one of the early occupations that was very much banned was professional singing, for example, wasn't it? Because it's thought the projection of you know, the projections of air caused by singing would increase the transmission risk. So I think it's a mixture of the two.
Thanks, Damien. Really important point. Nick, did you want to come in? Sorry, you were waving at me.
Well, I was just going to say, yeah, no, I absolutely agree with that, that there are specific kind of occupations and work activities, I suppose, often in relation to healthcare, dentistry, personal services, which are, you know, in a sense, they're not replicated in other environments very much. But obviously, most work activity is not like that.
Thanks, Nick. Any other comments from the panel?
Yeah, I think I would agree with what Damien and Nick said, and it's a combination. I think from what you propose is not one or the other, Andrew. I think it's both. I think it's both that there's a coalescence of factors that are concentrated in certain workplaces that you know that bring the risks that perhaps are happening outside work into the workplace, but there are also kind of workplace exposures that clearly lead to an increased risk in certain situations. And I think our kind of mortality analysis suggested that, you know, yes, perhaps a large amount of the differences in risk between occupations can perhaps be explained by other factors, but not entirely. There's still an important part that remains work related, workplace specific, I think.
I agree, and I think, you know, it illustrates the complexity of the situation we're dealing with, doesn't it? Where there isn't a single answer to a lot of these issues. It's how we bring all of these learnings together to try and unpick exactly what is going on. And on that sort of basis, what do you think are the important knowledge gaps that we still need to resolve? Clearly, we've started from a position where we knew nothing at all about SARS-CoV-2 to one where we know an awful lot more. But I think the transmission area is one area where there's perhaps still quite a lot of unknowns. So just interested in your views as to what those might be and how we might go about resolving them. Lizzie, do you want to?
Yeah, I'm happy to chime in there. So the thing that's really keeping me up at night is the emergence of new variants. And I think this is particularly relevant to all of us. But one thing that's worth bearing in mind about this is that while we've had a really fantastic vaccination rate in the UK, is that globally vaccine coverage is still limited and we see these massive inequities. And so while there's transmission happening anywhere, that puts us at risk in the UK as well. And so I think what we're going to need to continue thinking about is kind of what are the dynamics that play out and what does transmission look like in a partially vaccinated population? And so touching on some of the work that Nick has done. And how do we handle this? And how do we also think at the same time globally about the pandemic situation, and how do we do that through an equity lens?
Thanks, Lizzie. Let's move to Marty. What do you think the gaps are that we still need to think about?
Yeah, I think Lizzie clearly hit an important element, the international aspect of this, because we can control perhaps things in the UK, perhaps through vaccinations and our workplaces reasonably well, but internationally, I think this is something that's going to play on for a long time, and that will affect us too. The other kind of area that I think would be of interest is that we still don't really understand the kind of relative importance of different activities. So we say that, you know, household is important. We say, okay, going to a nightclub might be important. Going to work might be important. Taking public transport might be important. But we don't really understand how the relative risks are of these kind of various activities. And I think that would be, you know, I think going forward, an interesting thing to trying to understand better, because clearly that will then also demonstrate where we need to put our efforts in mostly.
Thank you. I'm going to finish with two very quick questions for each of the panel members. And the first one of those, I'm going to start with Dana, if I may, which is, what have you learned personally as a consequence of being part of this programme?
So thank you, Andrew. So I would say, to be honest, I've been here for a few weeks now, and I've really been pushed into a world of public health, occupational health and infectious diseases. And I think overall, how collaborative this process is what I've really learned. You know, everyone has their own expertise, whether it be the medics, the scientists, the occupational hygienists, everyone comes in to do this research, and it's all, you know, pulled together for the policymakers. And also, I guess, also how committed, you know, professionals are in trying to communicate this to the public. So with the previous question, you know, what are the gaps in transmission? You know, another gap is how do you communicate what we're learning to public, because at the end of the day, it's the public that has to follow this guidance and choose whether to follow it or maybe ask more questions to understand why we're doing what we're doing. So that's what I've learned personally.
And that's a really important point, and getting the message across is absolutely critical, isn't it, to making that difference. Very quickly, Nick, a sentence from you on what you've learned as being part of this process. Off mute, ideally.
Yeah, to unmute myself at the right time. Well, an enormous amount. I mean, I think, infectious diseases have not hitherto been a major topic for occupational health research, I think. And so there's a huge community of scientists that have had relevant skills and expertise that have translated that skills and expertise to a sort of new area in response to a huge challenge. And so I include myself in that group. And so we've learned an enormous amount, all sorts of different levels about the, you know, infectious disease transmission and epidemiology, which at a kind of personal level is very rewarding.
Thanks, Nick. We're out of time, but I noted one really important question, which I'll finish with, which was from Conrad, saying, how is the Protect research package being evaluated and what does success overall look like? And I think success overall for me means that when the next pandemic starts, we aren't starting with a blank piece of paper, which is what we were doing really when we picked up the mantle from Sir Patrick Vallance to start this work. We didn't know a huge amount, if anything at all, about how this was being transmitted. And we're now at a situation where we're able to provide simple, practical advice. So for me, that's our step on the journey to success. but leaving something as a legacy product that will enable people to move more quickly, perhaps, on this, I think is really, really important. So with that, thank you very much indeed. Thank you to all the speakers. It's been a really, really interesting session, and thank you for your interest in the Protect programme. There have been other sessions, I know, over the course of the last couple of days, and I'm speaking again on Friday at the last session. So please join us for that. And with that, have a great rest of the day. Thank you very much indeed.